Thank you.
Thanks for initiating that at the Chateau.
Thank you.
We saw it in action.
Hi. I'm interested in the role of the medical director in an assisted living facility where there are really no attending physicians other than the medical director.
So the question related to assisted living is very different than the nursing home. And I'm glad you brought that up because I didn't really focus on other environments where there are medical directors. Interestingly, not every assisted living facility in the country even has to have a medical director. So there are lots of assisted livings that don't have a medical director at all. And basically assisted living is more of a residential facility for individuals that need a little bit more help. And so it does not have the same regulatory burden or oversight as the nursing home. So we have probably gone too far in terms of regulatory oversight in the nursing home, and we could probably use a little bit more. And I have to be very careful when I say this because usually when you open the door and the feds or the state get involved in regulatory oversight, legislators start to get involved, and before you know it, you have more regulations than you can actually use and use effectively, and a lot of times it interferes with the care that you're providing. Having said that, in the assisted living facility, there are opportunities for a medical director. So I'm the medical director also for our assisted living facility, Orchid Terrace, over at Moorings Park. And I attend our monthly quality assurance meetings. I do follow some residents that are over there. We will actually stop in and see some residents where there's concern about care. It does provide a real advantage to an assisted living to have a medical director, particularly one that is there fairly often. And for the attending physicians in an assisted living facility, unlike the nursing home where the attending physician usually comes into the facility, in assisted living, they're still considered sort of housing in the community. And in that circumstance, just as you would go from your house to the physician office, the assisted living facility generally will provide transportation to the physician office. There have been a few assisted living facilities where I've had some involvement, either as medical director, well, always I've been a medical director where we've provided attending privileges, but where I've also been an attending physician where we have had physician office space in the assisted living facility itself. And so many of the residents would see the physician who would come to that office space in the facility. So while they technically left, they were really still on campus. The majority of assisted living facility residents, however, leave the campus completely and go to the physician's office. The assisted living facility does have the responsibility of providing transportation to those physician office visits. And that's generally true throughout the country. There are a few exceptions to that. The medical director, if they're in place, will help to oversee the caliber of care, the quality of care, and when there are concerns about particular residents or about physicians breaching the standard of care, again, the medical director will come on board and either have direct contact or indirect contact with the attending physician to make sure that the appropriate care is carried out.
How does hospice work in either the assisted living or the skilled nursing? If the hospice doctor's in charge, medical director, how do you like that to work at the Chateau?
I'll answer that question in terms of how I like it at the Chateau. I'll also answer it in terms of what often happens in other environments. So at the Chateau, we do use hospice. We use hospice for our residents, and some people say, well, this patient has end-stage dementia, they really don't know what's happening, so the counseling services, maybe even the volunteer services, are not really providing a lot for the resident. Why are you going to use hospice in this circumstance? Sometimes I will bring hospice on board, even though I have lots of background in hospice. I've been a medical director. I used to actually be the president of the Hospice Network of Maryland, so I've been involved in hospice for a number of decades. But I will still bring the hospice team on board, even in the nursing facility, because one of the benefits that can be provided through hospice has nothing to do with services that are provided while the patient is here. And that is bereavement counseling that occurs for family and for our staff should they need it after a patient dies. That's a very wonderful service that's available. There are some other things that change in terms of how durable medical equipment are obtained, the reimbursement for medications, and even the physician services reimbursement changes a little bit. In many facilities where we don't have a specific pain expert or we don't have somebody with expertise in hospice, they will still use hospice because it brings on additional services such as pain expertise, palliative care in general, where even some of the nurses in the nursing home may not have adequate training to oversee that. When there's respiratory distress, it can be very upsetting for some of the staff that haven't dealt with that. The hospice group is generally right on top of that. They have the expertise to be able to handle most of the palliative issues that come up towards the end of life in somebody who's in hospice. So many nursing homes will use hospice relatively commonly for people that are at the end of life. When we talk about end of life and the hospice benefit, we're talking about people that have a 6-month prognosis. As it turns out, most people who are referred to hospice have less than 6 months to live. And unfortunately, if we look at the median number of days, it's only a couple of weeks, and so usually hospice is brought in right at the end. We probably would serve our patients better if we brought in hospice earlier. Having said that, if we do look at the average length of stay in hospice, it is actually increasing, and so whether you look at mean or median, the numbers are a little bit different. In essence, though, we are doing a better job of making referrals to hospice at an earlier point, but because there are many, many more referrals to hospice, those that are made sort of at the end of life give us a number that looks a little bit worse because it's only a couple of weeks, but we have many patients that we've referred to hospice that have lived actually beyond the 6-month period of time. And so occasionally you'll refer people so early and hospice will recognize that they're probably appropriate, but over time the disease doesn't progress the way you thought it did, and they may take a hiatus from hospice and then come back later when the disease sort of manifests itself a little bit more aggressively.
Next question? It's yours, Clark.
Got one right here.
I'm sorry, I missed it. Question?
I don't know if this is, I'm new to this, so I don't know if this is an appropriate question, but do you get involved as the medical director in evaluating an individual as to whether they're appropriate for independent living or assisted living?
The question about evaluating folks whether they're appropriate for independent or assisted, the attending physician will often do that. The medical director, in certain circumstances, will also get involved in doing that. So let me draw a couple of different scenarios. In a continuing care retirement community, like Moorings Park, for example, everyone who goes to Moorings Park is evaluated for their level of independence. And it is anticipated that everyone that's going to come to Moorings Park will come on board as an independent senior living in independent housing. And the screening process is used to determine whether or not, on average, we expect that they will be independent for the next 7 years. That's very different than the evaluation for assisted living. So if you're out in the community and you are thinking about going to an assisted living facility, there is actually a form that needs to be completed by your attending physician. And this is true even in the CCRC. So if I send somebody who is independent living at Moorings Park to Orchid Terrace, our assisted living facility, there's some paperwork that I need to be able to complete to document that they are indeed in need of assisted living facility services. That is also true of the nursing home. Everyone who goes into the nursing home, even for just a brief stay after the acute hospitalization into rehab, for example, a form has to be completed, and it's a form from the federal government that has to be completed demonstrating that, at least for Medicare patients, that they are indeed eligible for a nursing home and that they need the services of a skilled facility like that. And that documentation has to be signed by the attending physician. And without that documentation, Medicare will not cover reimbursement for anybody who goes into that nursing facility. Thanks.